Hey, what's up, class? Got a very short presentation here. We're going to touch on ACLS pharmacology, just to kind of help prepare you, give you something to think about as we move into next semester. So you know the deal. Quick disclaimer, educational purposes only. It doesn't replace any of your readings or formal education. This is only meant to help you. Also, we're going to say the term ACLS a lot or the acronym ACLS a lot. Don't believe it's trademarked, but if it is, I don't own it. So the main thing we're going to get into is just a brief introduction to some common ACLS medications. We're only going to talk about adult dosing. You'll get into pediatric dosing when we get into PALS. At the end, there's going to be like a quick scenario to kind of show you the why and the how we give these medications. And this is going to be like a 1,000-foot view. We're not going to get into fine details over classes and mechanism of action, pharmacokinetics, pharmacodynamics. That's not what this is for. It's just to get you more familiar with them. Consult your drug cards for those fine details. First med that we got is adenosine. I believe sometimes you may see the trade name Adenocard. So adenosine is an AV nodal blocking agent. It slows conduction to the SA node. The time you're going to use adenosine is for those rapid narrow complex tachycardias, mainly SVT. So you get a patient who's got a rapid heart rate, you look on your EKG, their QRS is narrow and regular, some type of SVT. Adenosine can slow it down. First dose in adults is going to be 6 milligrams. If it doesn't work, you can repeat it with 12. Now you got to push adenosine really fast. It's got a short half-life. So it's a rapid IV push. So you want to administer it quickly and then immediately follow it with a flush or a fluid bolus. Um, Now keep in mind that adenosine, you may get like a sinus pause while it slows conduction through the AV node. So patients may feel flushed or a heavy sensation in their chest. So just give them a heads up if you have to push it because they're going to feel like they're on a roller coaster. The next med we got is amiodarone. So amiodarone is an antiarrhythmic, and it's got qualities of like all channel blockers. So it's kind of like a sodium channel blocker, kind of like a potassium channel blocker, and kind of like a calcium channel blocker. So some people will call it a multi-channel blocker. It primarily treats ventricular arrhythmias like VFib or VTAC. Sometimes you can use it in arrhythmias like AFib RVR for rate control, but a lot of times it will actually convert that AFib back into sinus, which may be a bad thing if they're not anticoagulated because it can throw clots and stuff like that. But again, mainly amiodarone is used to treat ventricular arrhythmias. In cardiac arrest, we can give it for refractory VFib or VTAC. So if we've shocked them a few times and nothing's working, we can use amiodarone kind of like a chemical shock. In adults, we start with 300 milligrams IV push for that first dose, and we can repeat that. We can repeat it once at 150 milligrams, so half a dose. And of course, this can be IV or IO. Same as all these meds, they can be IV or IO. Now, if we have somebody with a pulse, so somebody not in cardiac arrest, so say we have like VTAC with a pulse, we can give an amiodarone infusion of 150 milligrams over 10 minutes. And traditionally, and I believe they teach this in ACLS, if you convert a patient, whether they were in cardiac arrest and you give them amio, or if they had VTAC with a pulse and you gave them amio, if you convert them back to sinus rhythm or a normal rhythm and you end the arrhythmia, then after you give them that main dose of amio, you can put them on an amio infusion or a maintenance infusion at 1 milligram a minute. And the easiest way to do this is you take 100 milligrams of amio and you squirt it in a 100 bag, and you give 1 ml a minute, or a drop every uh, 60 seconds. 1 drop per second with a 60 drip set. Sorry. Now, amiodarone's got a super long half-life and it can be toxic. So a lot of times these patients, if they get amiodarone, um, they'll have to be monitored at the hospital because high levels of amiodarone can be toxic over time. Next, we have the medication atropine. So atropine is an anticholinergic medication. And if you think of the heart as a car, there's two ways to make a car go fast. You can either put your foot on the gas and speed up, or you can take your foot off the brake. I like to say atropine is like taking your foot off the brake. The atropine increases conduction to the AV node, and it is used to treat symptomatic bradycardia. So essentially, when someone's bradycardic and they're hypotensive, and it's because of the slow rate. The dose is 1 milligram, and it can be repeated to a max of 3 milligrams. We used to give 0.5 to 1 milligrams. That used to be the dose in ACLS, but we found that if we give too little atropine, then that can actually cause rebound bradycardia, so it can make things worse. So the dose, easy to remember, 1 milligram. You can repeat it 2 more times for a max of 3 milligrams as needed. Now, atropine, remember, it works on anticholinergic med. It essentially works on the AV node. So it may not work in second degree type 2 or third degree AV blocks if the problem is distal or beyond the AV node. So just keep that in mind. Those rhythms, you may have to go straight to pacing. Next, we got dirty dopamine. So dopamine is a vasopressor. It's very old medications, largely fallen out of favor, but it's still around and it's still in most people's drug boxes, and you'll have a few docs who are obsessed with it. Nonetheless, it is a vasopressor. It has both beta and alpha properties, so it can affect inotropy and chronotropy. It can make the heart beat stronger, and it can make it beat faster, and it can also constrict our blood vessels. Interesting thing about dopamine is it's dose dependent. The effects you want vary based on the dose that you get. In ACLS, it's going to be indicated for shock or that hypotension or symptomatic bradycardia. So we would give it in doses where we'd want more beta effects to get that heart rate up, and we would give it in doses that affect the alpha that gets that alpha effect if we were giving it for hypotension. So the dose range is going to be 5 to 20 mics per kg per minute. And again, this is largely fallen out of favor because they find that there's an increased risk of arrhythmias, and I believe the morbidity and mortality doesn't work out as well compared to other vasopressors. Epinephrine is a sympathomimetic. It's a vasopressor, and it's an alpha and beta agonist. Epinephrine is like the pharmacological multi-tool. It does a lot of things. In ACLS, it's going to be indicated in cardiac arrest. You're going to give your 1 milligram IV push every 3 to 5 minutes, and that's epi 1 to 10,000, or 0.1 milligram per 1 ml if you see the concentration written differently. It's also indicated in symptomatic bradycardia and shock. So in symptomatic bradycardia, ACLS generally calls for that dose of the infusion of 2 to 10 mics per minute, and that gets you mostly a beta effect with chronotropy, so it increases that heart rate. Also for hypotension or shock, you're going to probably see the dose of 0.1 to 0.5 mics per kg per minute. So at a 100 kilo person, if you start at 0.1, then you're going to get 10 mics per minute. How that math kind of works out. Now with the epi, it's generally the second line vasopressor that's used because there's also an increase in the risk of arrhythmia, similar to dopamine, but not nearly as bad. Now, a lot of times we don't have prepackaged epi drips in EMS, so if you're going to make your own, there's a few ways to do it. There's the dirty epi drip, which is where you either squirt 1 milligram of cardiac epi, or you draw up 1 milligram of epi 1 to 1,000 and you put it in a 1,000 bag, and that gives you a concentration of 1 mic per ml. That can be a little hard to do your math. A kind of an easy roundabout way is to take a 250 ml bag of saline and squirt 1 milligram of epi in it, whether it's 1 to 10,000 or 1 to 1,000. Either way is fine, and you get 4 mics per ml, and then you can kind of titrate your infusion from there. Next, we got lidocaine. So lidocaine is also an antiarrhythmic. It's very similar to amiodarone. It's used in ventricular arrhythmias. If you have a patient in cardiac arrest and they have refractory VFib or VTAC, you're running your code, you've shocked them a few times, and nothing's changing, you can give them an antiarrhythmic. And the initial dose of lidocaine is 1 to 1.5 milligrams per kilogram IV push, and you can repeat that at half the dose after 5 minutes if needed, and you can keep repeating that after 5 to a total max dose of 3 milligrams per kilogram. Be cautious, it may cause hypotension and bradycardia if you use it in somebody with a pulse, but most commonly lidocaine is going to be used in cardiac arrest on refractory ventricular arrhythmias. Similar to amiodarone, if you administer lidocaine and you do get conversion, some places may recommend that you do a lidocaine drip after as a maintenance infusion, and that's generally 2 to 4 milligrams per minute. And you'll probably see those pre-mixed bags of lidocaine on your truck. But 2 to 4 milligrams a minute is typically the maintenance infusion for lidocaine. Next, we got norepinephrine. Norepinephrine is becoming the most preferred vasopressor as the GOAT. It is a vasopressor. It's a sympathomimetic. It primarily affects alpha receptors with some beta properties. It's indicated in shock or hypotension. Most commonly, this is getting used after getting ROSC and your patients are still hypotensive despite some fluids. The dose is 0.1 to 0.5 mics per kg per minute as a continuous infusion. Some literature or some resources may recommend 2 other starting doses. They may recommend 2 to 10 mics per minute or 8 to 12 mics per minute to start out with. So just do what your protocols say. But the kind of textbook ACLS dose is that 0.1 to 0.5 mics per kg per minute for your infusions. Also be cautious because norepi can cause some necrosis when it gets into the skin or if it extravasates out. And again, this is becoming the most preferred vasopressor out there. Here's a few other meds you may see while going through ACLS. This isn't a conclusive list, but these are just some common ones. So procainamide, it's an antiarrhythmic. Sotalol, it's an antiarrhythmic. Mag sulfate is commonly used to treat torsade de pois, or that polymorphic VTAC. Usual dose is like 1 to 2 grams in a 100 bag over 5 to 60 minutes. Those are just general kind of ACLS recommendations. You also may see vasopressin. So vasopressin is an older vasopressor that's it doesn't have any effects but vasoconstriction. And used to, they would alternate your first dose of epi. You could do vasopressin if you wanted to, but largely we don't use it more, and it's not recommended in the current ACLS guidelines, but you may see it. Now we're going to kind of roll into that scenario, and you're going to see how we use a lot of these medicines. So our basic scenario, we got a 50-year-old complaining of palpitations, and we've got a heart rate of 200. We have a blood pressure of 130/90, and they're breathing 22 times a minute. So we've got a stable patient, and their EKG, it looks like a rapid, narrow complex tachycardia that is regular. So kind of thinking back in your mind, think about what meds we can use for that. All right, so we administer adenosine to try to slow that SVT down. So 6 doesn't work, so we can go to 12. So we administer 12, and it goes into this rhythm that we see below. And this patient is unresponsive without a pulse. So think about what rhythm this is. Think about what you would do and what meds you could consider or what treatments you could consider. So we start CPR, we defibrillate them. We start giving our cardiac epi, our 1 milligram of 1 to 10,000 every 3 to 5 minutes. And looks like that VFib was refractory. So we know that when we have refractory VFib, we can consider an antiarrhythmic. So we go amiodarone at 300 milligrams for our first dose. And it looks like we get a rhythm change. So on our next rhythm, looks like we got ROSC. And we have this rhythm below. Appears to be an irregular type of AV block. So you think about kind of what you see there. And we've got a blood pressure of 60/30, a heart rate of 45, and respirations of 10. So we started our treatment, we gave some fluids, and that heart rate's still staying bradycardic. They ran a 2nd degree type 2 heart block. We administered a milligram of atropine because we needed to speed that heart up. And our new EKG looks like this. So that looks a lot better, doesn't it? So we gave them that atropine. We corrected their rate. We got our current vitals now. A blood pressure of 70/40, still not that good. Heart rate 78, so that came up, and we're breathing for them at 10 breaths a minute. So we've corrected the rate. They're still hypotensive, so we need to go ahead and treat that hypotension. We've already given fluids in our scenario, so we're going to administer a vasopressor, and we're going to start with norepinephrine. And we're going to do that at 0.1 mics per kg per minute for our 80 kilo patient. I want you to kind of pause, think in your mind, what would your starting dose be for that? Think about how you'd set it up and how you would administer that. So to recap, this little mega code that we just ran, it involved almost every ACLS medication. We had adenosine, epinephrine, amiodarone, atropine, and norepi. Um, Biggest thing for you to take away from this is there's not a ton of meds in ACLS. Just wrap your mind around a few important ones. Get a strong knowledge of a few important ones, and that's what's going to help you the most. Okay, so don't get too nervous. Everything's going to be all right. If you can remember just the meds that were listed in this video, then you're gonna be a top 10% of the people that do ACLS. So don't worry. Here's some resources and references where I got this information from. So most of this came from the 2020 ACLS Provider Manual from the AHA. Additionally, this ACLS handbook here that's available on this website here, nhcps.com. This is a great website. They have free ebooks over ACLS and PALS. Additionally, they have some free interactive ACLS and PALS courses that you can take. Just go to the free resources. Do not feel like you have to pay for anything. You can access everything on this site for free. They offer paid stuff, but don't pay for anything. You can do it for free. Let me know if you have any questions or if anything was unclear. That is what I have. Thank you.